Good afternoon. Welcome to the Adrenal masterclass. Those who attended our masterclass series last year, they bring you the latest updates of clinical and practical relevance, as well as the state-of-the-art science underpinning novel diagnostics and therapeutics. Our speakers today do not need any introduction. They are at the forefront of their field in endocrine research and internationally renowned for the work they do. Without any further ado, I will invite Professor Maurice Brown to tell us about non-invasive management of unilateral primary aldosteronism. We are very fortunate to have you, Professor Brown. Over to you.
Well, my thanks to you, Amir, for asking me to speak at this meeting. I gather there are around 700 of you online. Sometimes we wonder whether there are 700 people in the world who have heard of primary aldosteronism, so underdiagnosed is the condition, but perhaps all of you are those listening to the talk. It's very timely as you're here, and I'm hearing some background chat.
Please mute. Please make sure you're muted. Apologies.
So I have one disclosure. I've been involved with development of the aldosterone synthase inhibitor, which I'll briefly mention at the end of my talk. There are numerous hurdles to making the diagnosis of unilateral primary aldosteronism and bringing that patient through to surgery and cure. And that's a shame, because this is the commonest single cause of hypertension that is potentially curable. And my talk is going to concentrate on our attempts to get away from the invasive hurdles towards something that's completely non-invasive or minimally invasive. It's 70 years since Jeremy Conn first described a patient with an aldosterone-producing tumor, which was only a year after the hormone aldosterone had been discovered by the husband and wife team of the Tates in the Middlesex Hospital in London. And over the 70 years since then, the average size of a tumor that we're able to discover has diminished greatly in size. And that leaves the techniques we use as something of a sledgehammer to crack a nut, still taking out a whole organ for the sake of these rather small tumors which secrete the aldosterone excess. And in fact, nothing has really changed in the last 30 to 35 years that's routine in the clinic or in guidelines. Whereas by contrast, alongside the clinical change or lack of it, the last decade and a half has seen an explosion of new discoveries and interest in the molecular field. And part of my talk will address how these molecular discoveries can now impact on routine clinical practice. And this sort of pyramid that I use to summarize the discoveries reports three main innovations of clinical importance. One was the development of very specific antisera, which can distinguish the almost 99% identical enzymes that make cortisol and make aldosterone, showing that the commonest type of what I sometimes call classical Conn's tumor actually contains more of the cortisol-making enzyme than the one which makes aldosterone. The second development, which I'll be saying more about, is the development of PET-CT scans, which allow us to visualize in vivo the tumors which secrete aldosterone, and to recognize that actually the commonest of these rather minute tumors, which are stuffed full of the enzyme making aldosterone, and which light up like a light bulb on these PET-CT scans. And then the third development was the discovery that most of these tumors have hallmark somatic mutations, meaning the mutation arises in the tumor, not in the germline. And I'll be telling you about the clinical differences we now recognize between tumors of different genotype. Now, these small tumors turn out not, in fact, to be the bottom of the pyramid. And much of the interest in the last few years on the research side has related to the discovery using the specific antisera for aldosterone synthase that most of the adult human zona glomerulosa has stopped making aldosterone, probably because we eat too much salt. and leaves us with these pockets or clusters of cells which are making aldosterone, which are present in probably at least 50% of you listening to this talk. And one of the questions is whether these are pathological or a normal response to aging when aldosterone has been switched off in the rest of the gland. And our latest scan, which we're developing with the group at UCL, which is very specific for the aldosterone synthase enzyme, is probably able to see at least clusters of the clusters in the adrenal gland. So what I'm going to address are some of the innovations making use of these molecular advances. One is the PET-CT scan. One which is not so molecularly based, but we need the PET-CT to visualize what we're targeting, is our use of ablation via the stomach. That's our minimally invasive alternative to surgery. I'll then be telling you how we use molecular techniques and surrogates for these, for deciding which patients are going to be truly cured by whether it's surgery or ablation, and then finish, as I mentioned, with a couple of slides on the new class of drugs. So firstly, the imaging, and I've been involved developing a ligand that homes in on the adrenal glands since around 2008. And the ligand that we've used until very recently is called carbon-11 metomidate, which anesthetists used in the 1970s and 80s, and its cousin etomidate is still in use to this day. And this recognizes the binding site of the enzymes which make aldosterone and cortisol, and we render it relatively selective for the aldosterone enzyme by pre-treating patients for 3 days with dexamethasone. So this is one of our scans. We've probably done around 500 or 600 of these now in the intervening years. And you can see how the ligand recognizes a reasonable sized tumor, in this case, in the adrenal. There's a bit of uptake in both the normal adrenals, and with metomidate, there's some background uptake in presumably related cytochrome P450s in the liver. So that's the non-invasive test. And the study, which I'll tell you the headline results now, was a within-patient comparison of the PET-CT with adrenal vein sampling. Many of you will know that this technique is still a bit of a technological tour de force for the radiologists, because they have to get the catheter into about a 1 millimeter diameter vein on both sides. And on the right, that's challenging because the vein drains directly into the inferior vena cava. So in the study, we hypothesized that metomidate would be at least as effective at adrenal vein sampling at predicting the outcomes from surgery. So all the patients who came into the study had proven primary aldosteronism, but we didn't know whether they were unilateral or bilateral. We were helped that during the course of this study, which we started in 2016 and published in 2023, there was an international consensus on how to assess the success of surgery, so-called primary aldosteronism surgical outcomes, or PASO criteria. And they divide into biochemical and clinical measurements, biochemistry being mainly aldosterone, clinical being the blood pressure. And in most studies, there's somewhere around 90% success at the biochemical level. At the clinical level, the success is okay if we accept partial, meaning that there's been a reduction in blood pressure or the number of drugs, but much less if we ask for complete cure of hypertension. I'll come back to this point. So these are the results we obtained in the 142 patients who came into MATCH, of whom roughly half came to surgery. And the question is, were the two investigations, the scan and the adrenal vein sampling, as good at predicting the outcome? Now, this one's not for the faint-hearted, so I'll tell you what it's showing you rather than necessarily trying to explain it all. But I might just say, as an aside, that there has been a real dearth of prospective studies in primary aldosteronism, and this study was an opportunity to apply the rigors which are standard in some other fields. And what the forest plot does is calculate the difference in accuracy of the two investigations. Remember, every subject had both investigations at predicting each of these four outcomes. And then by plotting the 95% confidence intervals around the mean difference in accuracy, we can detect superiority if these confidence intervals don't cross zero, and clearly they all did, and non-inferiority if what's called the lower bound of the confidence intervals do not cross the preset inferiority margin, which we had at 17.5%. So we were able to say that metomidate, which numerically was slightly superior to adrenal vein sampling, but statistically is non-inferior. In other words, it can now replace the invasive standard test. So I'm going to finish this section of the talk with a little diversion into the question whether we can predict this group of just under 30% who truly come off all their drugs and have a normal blood pressure. And the importance of maybe limiting surgery in the future to those who will be completely cured has been brought home to us by a result which is coming out in one of the two papers we're about to publish in Annals of Internal Medicine, where we followed the patients in the MATCH study all the way through to 2 years after their intervention. And by this stage, you can see that if we compare those who went to surgery in blue with those who were treated with long-term medical therapy, spironolactone or eplerenone, there is no statistically significant difference in the blood pressure. So we increasingly feel that it's a bit much to be putting people through what is major surgery, whether it's laparoscopic or not, if we can't give them a high likelihood that their blood pressure is going to be any better a few years down the track. So as I said in my first or second slide, we have a major interest in whether there are lessons from all our molecular discoveries in the field. And we didn't discover the KCNJ5 mutation. That was a landmark paper of Rick Lifton, but we discovered the common calcium channel mutation. And this data I'm about to show you suggests that there's a major difference between these two in the natural history. So we extracted RNA and or DNA from all the tumors that were removed during the course of the study, and then looked for the mutations, mainly the known ones and occasionally a new one. And this is a diagram in which the y-axis is the number of patients with each of the genetic variants. You can see that these are the two commonest, but with a striking ethnic difference that the calcium channel mutation is much commoner in the Black patients, who were almost 40% of our total, especially in those recruited at my hospital, St. Bartholomew's. So the interesting question now is there a difference in the surgical success rate between these, particularly these two main common variants? And the answer is yes, there's a striking difference. If I replot this data for only those subjects whose blood pressure is completely normal off all treatment, then it's really only the KCNJ5 mutation and a rather less common one, which is left standing. And again, asking the statisticians for help on a so-called logistic regression, you can see the genotype trumps everything else, including female gender and younger age. Now, that raised in our mind the question, why is it that genotype can have such a profound influence on outcome, especially since we've removed the tumor, which had this somatic mutation? And the thinking in the primary field has been moving towards saying that although traditionally, classically, we divide patients into unilateral and bilateral disease, actually, as so often in these days in medicine, there's a spectrum, and many of the patients who pass the tests for unilateral disease actually have something which we're beginning to call asymmetric, and the other side is not quite as normal as it looks. And this forthcoming paper now includes data which suggests that the gulf between the 30% who achieve complete clinical success and the almost 90% who achieve complete biochemical success is because we're over-diagnosing biochemical success. So let me just briefly explain how that what we're looking at here. The y-axis is the aldosterone-renin ratio, the PASO criteria say that someone whose ratio falls to less than 1,000 in the units where we measure it has achieved complete biochemical success. And in that case, we would expect to see that there's no trend in the aldosterone-renin ratio across the divisions into complete, partial, or absent clinical success. But it's obvious looking at this diagram that those with the only partial clinical success actually tend to have a higher aldosterone-renin ratio. And I think if we were more strict in our definition of complete biochemical success, we would find that many of those who are only partially cured are also not completely biochemically cured. And if you think about that, that must mean that the opposite contralateral adrenal is still having some autonomous production. So the color coding here is the genotype. And you can see that, as I've already said, the KCNJ5 genotype in blue accounts for most of those who are completely cured, whereas the calcium channel mutation in red, very few complete cures, and actually by 2 years, only one. And many of those do not really achieve complete normalization of their aldosterone-renin. So for reasons I don't have time to go into, but maybe we can come back to in discussion, we think this mutation commonly arises on both sides, and we know now that it causes those microscopic clusters that I mentioned on my first or second slide. Well, the good news is that we can predict who's got the KCNJ5 mutation by a urine measurement. Actually, this was done in the lab of Wiebke Arlt, who's about to talk to you. And when we measured the ratio of so-called hybrid steroid, 18 hydroxycortisol to cortisol, the hybrid steroid can only arise in cells that are making both aldosterone and cortisol. And you may remember from my pyramid slide again, I showed you how the antibody tells us that is the case with the classical Cons tumor, which is the ones with the KCNJ5 mutation. So we're testing this prospectively, but we think we can now select the patients who are going to be completely cured and begin to stay away from surgery in the rest. Well, finally, before I leave the imaging, I just want to say that a downside of carbon-11 metomidate, and why we've almost now given up on it, is it's only got a 20-minute half-life. So it has to be made on site in a cyclotron, and there are very few hospitals able to do this. So together with colleagues in Sweden and Cambridge, we developed an 18-fluoro analog, and this can in principle be done in any hospital that does 18-fluoro FDG scanning. And I've just put in a couple of patients to illustrate how interchangeable these are. Here's a patient with a large tumor on metomidate, very similar on the what we call CETO, except we don't have the liver background with the CETO. And here's one of our sort of light bulb, smaller tumors lighting up on the metomidate and the CETO. And we did both scans in 31 patients at the end of the MATCH study, what we call the MATCH extension, and this is what's about to be published. And you can see that in all but one patient who was predicted by the radiologist to be high probability of unilateral disease by metomidate, we got the same answer with the CETO. And in the last year or so, we've switched completely to doing CETO, and Cambridge make it and send it to us to use at Barts. So my next and second of the two main topics is the endoscopic ablation. And ablation has been around for a while, and it arises lots of hot views as to whether it's something that should be taking over in the field of primary aldo or not. And there was a very good, slightly exaggerated debate a couple of years ago at the Endocrine Society. And some of the views against ablation are that it's been of limited efficacy, not tested prospectively, you don't know what you're ablating, and the dangers of targeting the adrenal medulla. So a bit of this is illustrated by a picture from one of the retrospective studies illustrating that to tackle an adrenal on the right-hand side, you either have to approach posteriorly where there's a risk of pneumothorax, or through the liver, and you're aiming from quite a long distance away at a relatively small tumor. And we know from our experience that it can take an hour or more just to center the catheter in the middle of one of these small tumors. So we developed an alternative approach, which probably only works for the left-hand side, and that's certainly the only side we've tackled, where you realized that with the adrenal tumor sitting right next to the stomach on the left, we can approach them through the stomach. And here's the picture I showed you earlier on, illustrating that even if on an axial view, the tumor might seem somewhat distant from the stomach, on the sagittal view, which is a bit more like what the endoscopist sees, there's actually almost always a very short window from the stomach through to the tumor. And this is the view that the endoscopist gets with an ultrasound camera in the stomach. And this is the tumor. You can see the normal limb of the adrenal off here. And this is a picture of the catheter coming out from the end of the probe in the stomach. So this is the second paper that was accepted just in time for this meeting, and is coming out next month in the Lancet, where we published the results of our proof of concept study in 28 patients with unilateral left-sided adenomas. The patients who came into this study, many of them were people in whom surgery was not appropriate. So our key primary aim was not efficacy, but safety. But I will just comment on the ethnic diversity, which, as in our match study, our local community meant that a high proportion of our patients are the Black patients. And we think this technique may be particularly appropriate for those who have mainly the calcium channel mutation and are very unlikely to be cured by surgery. So the table on the right is our primary outcome data, which was surgery, and we pre-specified the major hazards that we wanted to be confident were very unlikely to occur. And you can see that using a CT scan and other obvious measurements within 24 hours of the study, none of these occurred. There was one patient who had a doubling of the amylase. I thought I'd illustrate next how, by combining this with the PET-CT scan, we can use this not just to localize what's about to be targeted, but by repeating the scan at 3 months after the intervention, we can see how effective the ablation has been. And these are 2 patients where the nodule was completely ablated. You see it's gone here. This is the normal bifurcation you're seeing with the tumor gone completely. And a third patient where there's a bit left behind, and even possibly some contralateral increase in the uptake. And these 2 patients were completely cured, whereas this one, we obtained a partial cure. This is a more recent pair of pictures using the CETO scan with one of our patients with a left-sided tumor. And here you see the axial, sagittal, and coronal view at the pre-ablation stage, then repeated after 3 months, where the tumor has gone altogether. So one of the criticisms of the ablation technique had been that you couldn't know what had been ablated. But in fact, we get fine needle biopsies from these tumors, and these are the 3 patients for whom I showed you the scan. H&E stained for the CYP11B2, which is aldosynthase, and stage B1, which is the enzyme making cortisol. And you can see that in the 2 patients who were completely cured, these were tumors that were almost purely aldosterone synthesizing, whereas the patient where we only had a partial cure was clearly more of a cortisol rather than an aldosterone producing tumor. So to summarize the efficacy data that's coming out in the Lancet, 75% of the patients achieved a biochemical cure, so less than in the surgical series, but as I said, not all the patients were appropriate for surgery coming into this, and just under 50% achieved complete or partial clinical cure. And we had one pre-specified biochemical measure of improvement, the aldosterone-renin ratio, and here we saw around 75, 76% reduction. Now, going from the results in this study to a pivotal comparison with surgery, we were very influenced by patients' expectation, because we felt one of the lessons was that ablation at the very best would be as good as surgery. It could never be better than surgery. And the likelihood was that there would be some patients with more than one nodule in the gland, or maybe the micronodules, who would not do as well. So we felt we had to ask, and we did this with an international group of patients organization, and we asked, my numbers just covered there, was 120 patients, what chance of success they would want after a minimally invasive technique compared to surgery in order to be willing to go ahead. And you can see that if you add up these two categories, actually slightly more than half of patients are willing to accept odds of success, which are actually only 50% or less of those of surgery, which I think tells us something about patients' aversion to having a major procedure. So to summarize, in this sort of version of the MasterCard advert, for those in whom we can predict a case in J5 mutation, we would recommend surgery, but for everyone else, medical therapy, or maybe when we finished our pivotal study, ablation. And this is an unashamed flag wave for the pivotal study. Then if you have patients who would be willing to have either surgery or ablation, do please think of letting us know. So briefly, because I can see I'm coming up to the end of my time, a couple of slides on the aldosynthase inhibitor. I've already mentioned that the structure of these two enzymes are very close, and just as with the anti-sera, it's been a challenge to develop drugs, of which there are now 3 in development, but only inhibit aldosterone but not cortisol production. I've been involved with baxdrostat, as I mentioned in my disclosures slide, and I'll show you one final data slide, which is from a phase 2 trial in resistant hypertension, which largely overlaps primary aldosteronism, and I'd previously shown spironolactone was the drug of choice for this group. So in this phase 2 study of resistant hypertension, the placebo-controlled reduction in systolic blood pressure hits double digits. 11 millimeters is actually almost the same as we had previously seen for spironolactone. And just published is a study in primary aldosteronism with another of the 3 drugs in development, dexfadrostat, which shows that the drug reduces plasma aldosterone by, this is aldosterone-renin ratio, by 90%, so even more than the figure I showed you for ablation. And this is associated with a close to, again, to 11 millimeter placebo-controlled fall in blood pressure. So to summarize, I've shown you non-invasive imaging, minimally invasive ablation, how we can use molecular measurements and their surrogates to predict who will be good candidates for surgery, and a very brief window into the new class of drugs, which hopefully will take over from all of this, just as in the field of stomach ulcers, omeprazole took over from surgery and other surgical techniques. So lots of people, of course, did the work that I've been showing you, and here's a picture of us all at one of our summer parties. Thank you.
Thank you so much for really a clear and interesting talk, and it's wonderful to have a preview of the data that is about to be published in the Annals and Lancet. 1 or 2 very quick questions. Could you explain the cooling effect that you briefly mentioned?
So on the right-hand side, the adrenal lies close to the IVC, and depending exactly where it is in the adrenal, might actually be almost touching. And the mechanism of ablation, of course, is either by microwave or radiofrequency waves to generate enough heat to destroy the tissue. But if that heat can be carried away by a high flow of blood in an adjacent organ, that makes it more difficult to reach a critical temperature that destroys the tissue. It's a problem with radiofrequency for reasons I don't quite claim to be an expert on. It's less of an issue as microwave. And in our wave study, we're using microwave ablation for the right side tumors that are very close to the IVC.
Fantastic. Thank you very much, Professor Brown. The talk will be available. Are you happy for the recording to be made available?
Yes, that's fine. Yes.
Thank you very much. Really great.
Okay.
Our next speaker is Professor Simon Pearce, who I think is with us. Just go to... Excellent.
Shall I just crack on and share my slides?
Yes, please. So, delighted to introduce Professor Simon Pearce from Newcastle, who will be talking about management of adrenal insufficiency. Thank you very much, Simon.
Okay, great. If you can hear me okay, I'll just get going. So this is quite a practical talk, and do shut me up if I go on for too long, because I've just got quite a wide-ranging sweep. It's going to be mainly about primary adrenal insufficiency, so Addison's disease and associated causes of primary adrenal insufficiency. Pardon me. That slides are jammed. Okay, that's better. These are my conflicts of interest. So I'm going to talk about diagnostic issues to start with, something about the relationship between glucocorticoid dose and quality of life, something about fludrocortisone and salt replacement, and if I've got some time at the end, I'm going to talk about the new medications on the block for these conditions. So first of all, diagnostic issues. Of course, 85% of cases of primary adrenal insufficiency in our clinics in the UK are due to autoimmune Addison's disease, but the remainder, about 15%, have a non-autoimmune etiology. And we reviewed this in a Lancet paper, myself, Oyston, Husabai, and colleagues in 2021, and we managed to find 35 additional causes of primary adrenal insufficiency, which are listed in that paper. So, of course, congenital adrenal hyperplasia is defects in steroidogenic biosynthesis associated with large adrenals, by and large, is one of the main causes of those additional 15%. But there are also infective causes, infiltrative causes, of which we tend to think about tumours, but I'm going to show some others, and some rarer genetic conditions. And then overall, some drugs are always important to bear in mind in cases of adrenal insufficiency. So this is an algorithm we actually published in the Journal of Neurology Physicians. I hope you can see my little pointer, but once you've got a positive synactin test, or if you like a failed synactin test at the top, we exclude concurrent or recent exogenous steroid use, and we do that pretty rigorously because patients often say, oh, I had an injection for my back or something like that, and it turns out they had an injection of triamcinolone into their back, and that's enough to suppress your axis and for you to fail a synactin test 6 weeks later. Many patients have multiple of these injections. You then measure ACTH if exogenous steroids have been excluded. If it's high, we're into primary adrenal insufficiency, and this is what I'm mainly going to talk about today. If it's low, of course, we're thinking about pituitary problems, and that requires some imaging as well as measuring the other anterior pituitary hormones. And that's not rocket science, that's just our general endocrinology. So once we've got the primary adrenal insufficiency, the most likely cause is going to be autoimmune. So we'll measure the 21 hydroxylase or adrenal autoantibodies by various different techniques. And if those are positive, or there's a very strong family history of autoimmunity or personal history of autoimmunity, we don't need to think much more about it. But if those are negative, then we're into an interesting diagnostic conundrum. And this really requires all our skills as a general physician sometimes, as well as a specialist endocrinologist. So the next thing is imaging to look for infiltrative infective hemorrhagic causes. And if that's normal, then we're in some genetic causes by and large. In a male patient, measure serum very long chain fatty acids because adrenal leukodystrophy will overwhelmingly be the most common next cause. So I'm just going to go through a few unusual diagnostic cases, bearing in mind this long and rather diverse list of non-autoimmune infiltrative causes in that Lancet paper. So I'd look that up if I was you. So case one, 66-year-old gentleman presented with hyponatremia, hypotension and a productive cough, was admitted to hospital with a diagnosis of presumptive pneumonia. He'd been known to have a right adrenal mass 2 years ago, and you can see that here on his imaging. Because of his electrolyte disturbance, shown there, he underwent an early synactin test. So he had a basal cortisol of close to 300, and it moved to 319 after 250 micrograms of synactin. So we on this assay, we were hoping for a response of over 550 nanomoles. His ACTH was very strongly elevated. Adrenal antibodies were negative, so he went on with further imaging, which showed this pattern here. Because we had negative antibodies, we went on and did serum very long chain fatty acids and 17-alpha hydroxyprogesterone, which were both normal. And then one of my smart registrars noticed that he had vitiligo on his digits. So we thought presumably this is autoimmune, but we weren't 100% convinced as the antibodies remained negative. And we quite often repeat antibodies after 3 or 6 months if we're in diagnostic equipoise with it. And so we re-imaged him a year later, and the radiologist reported some slight shrinkage of that right adrenal, so that was kind of reassuring. And then we didn't hear anything from him for a little while, but 5 years later, I got to see him again. His wife had died and he wasn't feeling great, fatigued, some weight loss. And so I thought it appropriate to re-imaging, kind of thinking he's probably cooking for himself now, which is why he's lost weight. But in fact, what it showed is the right adrenal gland was now very calcified. And interestingly, the radiologist reported some flecks of calcification in his spleen and some calcified nodes around his aortic axis there. And in fact, looking back, he had calcification in his spleen on his previous imaging as well. So quantiferon gold test was positive. So this is a rather late diagnosis of adrenal tuberculosis of the cause of this guy's adrenal insufficiency. So this is probably the most common cause after autoimmune, even in the Western world at the moment. So the only important thing about this is if we're going to treat him with rifampicin as anti-tuberculous therapy, we must increase his hydrocortisone dose because it's an enzyme inducer and will pretty reliably induce an adrenal crisis unless we increase that hydrocortisone dose. So next case is something a bit different. This guy was a 42-year-old man who presented with the first generalized seizure, having been previously well. This shows his brain scan showing these white matter densities here and here. And so neurologists call this leukodystrophy. So they did the relevant things, which was measure his very long chain fatty acids, which were positive, and a mutation in the ABCD1 gene was proven. And this is a gene on the X chromosome, so it's hemizygous. It's an excellent condition and predominantly affects men. So he was confirmed as having X-linked adrenal leukodystrophy and was referred for endocrine surveillance. So I saw him every year or 18 months for about 10 years. So this shows his synactin tests on the old assays where the peak needed to be over 550 nanomoles of cortisol. And so the black dots are the basals and the blue squares are the stimulated cortisol. So he stimulates quite nicely and passes the test for the first 3 years on the old assay. Then on the new assay, we're looking for a basal of over 300 and he's stimulated over 420. So he does fine on the stimulation test after 5 years. And after that, I get a little bored of doing synactin tests on him. So we just go on his 9 o'clock cortisols, which are all comfortably, well, that one was borderline, but the others were comfortably over 300. But then in 2024, he developed more symptoms and his random cortisol was, or his morning cortisol was lower, and he failed to stimulate adequately. So he developed his primary adrenal insufficiency over 11 years since his diagnosis of adrenal leukodystrophy. So what do we expect in this condition? So actually that's exactly average for this condition. This is a series of about 150 patients from the USA with adrenal leukodystrophy, and there's an 80% lifetime risk of primary adrenal insufficiency for males with adrenal leukodystrophy. And you'll see here, this is the onset of glucocorticoid replacement, 50% of patients in 10 years, so he exactly conforms to that. And in the next 30 years after that, the remaining 25% of patients who were going to develop adrenal insufficiency and need glucocorticoid replacement. Mineralocorticoid replacement, though, is only needed in about 50% of patients, so it can develop later. And also, it's a very heterogeneous condition. Even in families with exactly the same mutation, you can see different phenotypes, with one patient having severe neurological manifestations, the uncle maybe, but the nephew having no neurological manifestations at all, but adrenal insufficiency from a young age, etc. And this can lead to some distress in the families because they say, well, his disease is different to mine, etc. So just to recap, the very long chain fatty acids need this transporter ABCD1 to get into the peroxisome to be oxidized, and if that doesn't work, if there's a mutation in the transporter, the very long chain fatty acids build up and cause cellular cytotoxicity. And for some reason, that's a problem in neurons or in axons and in the adrenal gland. So that's the pathophysiology. So the last case is a bit of a curiosity, but it just will keep you on your toes in a way. 65-year-old gentleman presented once again, postural hypotension and weight loss. Sodium was 126, potassium 5.7, which raised the suspicion of adrenal insufficiency. He'd been evaluated 3 months previously by a community dermatologist. In the UK, we've got this group of people, at least in Newcastle, we have called gypsies or GPs with a special interest. So this was a GP with a special interest in dermatology who diagnosed palmar psoriasis at the ripe old age of 65 for the first time. He was a retired soldier. He had a poor response to synacthin, and so primary adrenal insufficiency was diagnosed, and his ACTH was duly raised. Adrenal autoantibodies were negative. So because of that, he had CT imaging, which showed these rather diffuse bilateral adrenal masses, and his spleen was a little bit on the bulky side and a bit patchy as well. I was thinking this was going to be lymphoma. We started him on steroid replacement, and he was awaiting evaluation and bone marrow from hematology to try and sort this out. But while he was waiting for that, he represented after discharge from hospital with sudden unilateral visual loss. And the ophthalmologist looked in his eyes and said, oh, he's got uveitis. And there's a test they always do for uveitis, which we normally don't do very often, which is a syphilis test. So this guy's syphilis test was positive, and these are bilateral adrenal gummas caused by syphilis in this 65-year-old man. So he's treated with 17 days of benzyl penicillin, which is a standard syphilis regime still. You can see his bilateral adrenal gummas regressed. Unfortunately, his adrenal axis never recovered. Interestingly, you can see also his spleen did actually shrink a little bit with the penicillin. So this is just a curiosity, but it behoves us to bear in mind that bilateral adrenal lesions can be associated with quite a lot more than our regular endocrine conditions, and we need to keep our general physician minds in gear when we see these patients. So this just shows you the age distributions. For autoimmune disease, of course, it becomes most prevalent starting in the teenage years and then into adulthood, hemorrhage and tumour at later ages, whereas the genetic conditions, congenital adrenal hyperplasia, adrenal leukodystrophy, and the genetic form of autoimmunity, or the monogenic form of autoimmunity, APS1, tend to manifest in childhood. So if we've got these patients and the imaging is negative, we can, and we don't have a firm diagnosis, in the NHS we've got this National Genomic Test Directory, and the R150 panel is basically primary adrenal insufficiency panel, and the ones I've labelled in red are just the ones that we've got in our clinic, in our routine adrenal clinic that we found over the years. So we've got about 150 patients with primary adrenal insufficiency coming to the clinic, and this gene panel tests for all these different ones if you're in any doubt. So that's like a roundup of the diagnosis. Down the left-hand side of this algorithm, measure antibodies, do a CT, and then think about genetic causes. We mustn't forget drugs, though, and this applies often with the suppressed ACTH cases, but really important not to miss this. So, of course, exogenous suppression in adrenal insufficiency, inhaled topical steroids. And it's worth asking and asking again about this, because sometimes it comes out a little bit later, or someone gets a message from the GPs a week or two later saying, oh, actually, they were on some steroids, which we hadn't realized before. Central suppression of the axis due to opiates, and I'm just going to show you a bit more about that, but tramadol or any opiate more potent than that can cause central suppression. Impaired steroidogenesis with ketoconazole or etomidate, to a lesser extent fluconazole, can cause that in high doses and chronically. Some drugs increase the clearance of steroids. These are CYP3A4 inducers, so rifampicin we've already mentioned. Phenytoin and topiramate will be the other classical ones that we seem to use a fair amount of still, rifampicin, topiramate, and then decreased clearance, ritonavir and itraconazole. These create this opposite problem. The patient will be on an innocuous topical steroid or perhaps a beclomethasone inhaler for asthma at low dose, and they develop adrenal suppression because they can't clear those steroids, and their ACTH becomes suppressed, leading to adrenal suppression in the long term. So it's definitely important to be aware of these drugs. This just shows you a bit about opioid-induced adrenal insufficiency. So this is a series of 102 patients taking chronic opiates. These are the ones with opioid-induced adrenal insufficiency, OIAI. And so the median dose of morphine equivalents per day was 140 milligrams. So that's MSD 70 milligrams twice daily. So these are pretty substantial doses. And it's a time-related thing. They've been on it for 96 months on average, so that's about 8 years of treatment, and they have this large cumulative opioid exposure. So a typical patient like this, when I approach them, I say, I think you've got adrenal insufficiency caused by the opiates. They say, well, doc, I've been on the opiates for 5 years, and this has only just happened in the last year that I felt so terrible. And so they say that means it can't be the opiates, and I say that's exactly the pattern for opioid-induced adrenal insufficiency, is what you're describing to me, because it takes several years of high-dose opiates to develop this problem. This is just a survey of 8 different surveys, and just to make it short, 8 surveys of opioid-induced adrenal insufficiency. 8 to 35% of people on chronic opioids had adrenal suppression across these different studies. So it's not that uncommon, and we need to be conscious of that, because a lot of patients are taking these drugs like oxycodone or tramadol and other submorphine opioids, which nevertheless can give you this problem. So for diagnosis, take a careful history. Non-autoimmune primary adrenal insufficiency has many etiologies. Tuberculosis may take years to manifest, and don't assume adrenal mass is a tumor, because you'll get caught out like I was with the syphilis case. Do think infection or hemorrhage. All patients with bilateral adrenal masses need serum 17 alpha hydroxyprogesterone measured, and urine steroid profile if you're then suspicious of congenital adrenal hyperplasia. Just bearing in mind there's no real phenotype of hyperandrogenism in a man, so these non-classical cases can catch you out in later life. So I'm just going to briefly talk now about the relationship of glucocorticoids and quality of life. This is data from the EU study. This was a large post-marketing surveillance study that the manufacturers of Plenodrome were required to do by the European Medicines Agency. So this is more than 1,000 patients with a mixture of primary and secondary adrenal insufficiency, about 2/3 secondary. They'd had adrenal insufficiency for about 16 years, and 87% were taking hydrocortisone, 5% prednisone, and 4% cortisone acetate. And this just shows you the dose frequency for the patients taking hydrocortisone. Very small number taking it just once a day. Most patients taking it either twice a day, but 45% of patients taking hydrocortisone 3 times a day. So we're going to look at the evidence for twice versus 3 times a day. And then the doses, you can see the most common modal dose was between 20 and 25 milligrams of hydrocortisone per day. The next most common between 15 and 20. So how does that relate to what we know about the requirements for steroids. So this is a classic paper from Lynn Laurier's group, where they measure cortisol production rate by stable isotope. And what they find is actually the cortisol production rate for the average person is 9.9 milligrams daily, plus or minus 2.7 milligrams. So around about 10 milligrams or 6 milligrams per meter squared per day. So our doses we're giving, we think the requirement is somewhere down here, and actually we're tending to give nearly twice as much hydrocortisone every day to these patients with adrenal insufficiency. This is European data, but I doubt it's very much different anywhere else in the world. So we need to bear in mind a few things, and this is beautiful data from Trevor Howlett, which is such a simple paper. I always come back to it. So he looked at patients who had adrenal insufficiency, mainly secondary, and their morning dose of hydrocortisone, and he just measured their serum cortisol an hour after their morning dose of hydrocortisone. So they were either taking 5 milligrams, 10, 15, 20, or 30 milligrams of hydrocortisone first thing in the morning. And if you're taking 10 milligrams of hydrocortisone in the morning, you achieve a peak cortisol of around about 550 nanomoles. If you're taking twice that dose, it goes up to about 630, 640 nanomoles. So we all think in our minds, if we double the morning hydrocortisone dose from 10 to 20, we'll double the serum cortisol. But in fact, we only increase it by a smidge. And that's because this is a 2-compartment system, and that there's cortisol binding globulin in the blood, which saturates at around about 500 nanomoles. And it's actually not very efficient use of your hydrocortisone to give more than 10 or maybe 15 milligrams in one dose, because you just tend to excrete and metabolize out the rest quickly, as it's not bound in the serum and doesn't have a duration of action. So we suggested some weight-related doses in a paper we published 10 years ago now in Current Opinions in Endocrinology, Diabetes and Obesity. If anyone needs this paper, just message me, I'll send it to them. So for smaller women, and quite a lot of women with Addison's disease are on this small side, 5 and 5 or going to 10 and 5 milligrams is sufficient. And I'm going to come on to why giving a third dose in the day may or may not be a good idea in the following slides. So this shows a beautiful paper from Würzburg on nearly 350 patients with adrenal insufficiency, mainly primary, about 200, and then 150 with secondary. And this shows you their quality of life using short form 36, SF36 questionnaire, according to their dose of steroids. Okay, so 10 to 15 milligrams in the white box, and the highest dose over 30 milligrams in the dark, and then there's a gradation between. So this shows you the different domains of SF36 according to dose, okay? And the lowest score is worst quality of life. So this is physical functioning, so-called role physical, bodily pain. GH is general health, vitality, social functioning, role emotional, and mental health. And you can see that for 6 out of 8 of these domains, the patients on the highest dose of steroid actually had significantly worse functioning than patients on much lower doses. When we look at the mental health, HADS, hospital anxiety and depression, they did at the same time. Similar story, people with high doses did worse for anxiety, probably not much difference for depression. And then they also nicely looked at the regimen, whether people were taking the hydrocortisone at 2 doses daily or 3 doses, and they controlled for the doses. So this just shows the data for people taking 15 to 20 milligrams daily, the same SF36 scales. Once again, the patients taking 3 doses daily did worse for almost every domain, and significantly so for social functioning, and the vitality and general health looks worse. Anxiety and depression were worse in the patients who were taking 3 doses. So the evidence that increasing or changing the regime to incorporate 3 doses is a good idea is not really there. And you might think, well, this is a strange data set from one German center. Well, it's a pretty big data set, and amazingly enough, there are 3 other large studies with more than 200 or more patients in, one from the Netherlands, one from Germany, that shows exactly the same. So I've spoken about this Blyken study. this Mayer study, also from Frankfurt in Germany, 200 patients with primary adrenal insufficiency, no correlation at all between the dose and the quality of life. And this Dutch study, Van der Valk, they found exactly the same as the Blyken study. The patients who were taking 3 daily doses of hydrocortisone, it was worse. They felt worse than patients taking 2 doses. And all these other studies show that higher or more frequent dosing was not superior to taking just the 2 doses, with the exception of this very early study where they just studied whether 2 doses of hydrocortisone, that's 20 and 10, was better than taking 30 milligrams all once in the morning, which surprisingly splitting the dose was better if you're taking 20 and 10. So we ought to be cautious about using split doses. So in Newcastle, we have this 10 questions which we like to ask patients. Do you have low spots during the day? Are you clock watching for a particular dose? In other words, by 11:15, are you wanting your 12 o'clock dose of hydrocortisone? And in that case, we'll move the dose backwards so it's nearer. Do you often miss a dose because you haven't noticed the time? Maybe that dose can be ditched if the patient routinely misses it and feels fine. Are they staying? Do they have to go to bed early, or does it keep them out of bed till 1 o'clock in the morning? Are they sleeping okay? How do they feel first thing in the morning? Worth asking about that, because many Addisonian patients have nausea and feel rough first thing in the morning, and they can't eat anything till 10:30, 11 o'clock until their morning hydrocortisone kicks in. So I'm just got a few slides on, or should I be quiet now, Amir, and take some questions, or have I got a couple of minutes?
Keep going, please keep going. Thank you.
Sorry?
Please keep going, that's excellent.
Please keep going. Okay, so mineralocorticoid deficiency. I was phoned by this gentleman's wife. He was an inpatient in one of our local hospitals, and he'd had 5 adrenal crises in the previous 6 months, and he'd been diagnosed with Addison's disease for less than a year. And every time he came into the local hospital, they with an adrenal crisis, they increased his dose of hydrocortisone. So he was taking 50 on waking, 50 at lunchtime, and 40 in the early evening, and no fluid cortisone. And he had this rather cushion-eyed appearance, double chin. He's got supraclavicular flat pads, facial plethora, and over the course of a year, we reduced his hydrocortisone to a much more reasonable regimen, and then introduced some fluid cortisone, and he's now a new man. He's back to work, and this really emphasizes to me the importance of mineralocorticoid in prevention of adrenal crisis. So if we think about the pathophysiology of adrenal crisis, salt depletion is really the prime thing. Hypotension, tachycardia, shock, cardiovascular collapse, electrolyte disturbances leading to back pain or muscle spasm. These are all mineralocorticoid effects. They're not glucocorticoid effects directly, which are slightly different. We certainly get these in adrenal crisis, but this is the stuff that hospitalizes you by and large, with the exception of hypoglycemia. So just one slide on adrenal crisis. Vomiting and diarrhea are the most common things. This is work actually done by the next speaker, Wiebke Arlt. But surgical recovery, this is 6% of adrenal crisis caused by dental surgeons or endoscopists or other doctors who do stuff without adequate cover. So these adrenal crises should be absolutely preventable. So what are the risk factors for adrenal crisis? So this is once again from the EUS study, nearly 2,700 patients now, and they matched 80 patients who had adrenal crises in the study to patients who hadn't for gender, comorbidity, and steroid use. So they were mainly taking hydrocortisone. But what was interesting is the things that were significantly different were the potassium is higher in the patients who'd had adrenal crisis, not much, but a little bit. Sodium was lower, significantly so in the patients who'd had adrenal crisis, and blood pressure was also lower. So this really underlines the idea that mineralocorticoid under replacement in these patients may be an important factor in why they develop adrenal crisis. So if you ask your patients with primary adrenal insufficiency, 25% of them, and this is well documented in several studies, about 25% of them will still have salt craving post-treatment. And this is a prime indicator that they're likely to be mineralocorticoid under-replaced. And these are all the funny things that primary adrenal insufficiency patients will eat, and they'll talk about them if you ask them, but they don't like admitting that they finish the pickles in the pickle jar and then they drink the vinegar pickle brine afterwards. But that's very common, and some of them will eat a lemon like an orange and all this stuff. So it's worth exploring that. Assessing mineralocorticoid replacement, though, is quite difficult. Renin does correlate pretty well with serum sodium, but renin is really a marker of renal perfusion and hence volume state, not sodium directly. So the sodium still trumps. If the person's hyponatremic, they can still have a normal renin, and particularly if they sit outside my clinic, and there's a Costa in our hospital outside the clinic, if they've drunk a 16-ounce coffee before the clinic and then they come in, they can have a low sodium but an absolutely normal renin because they've had a 16-ounce drink. And similarly, potassium does correlate with mineralocorticoid dose, and we need to be avoiding potassiums over 5. So we ask the questions: salt cravings, binging on salty or sour foods, postural lightheadedness, nocturia can indicate natriuresis at night, do they feel generally washed out? And this is the order: sodium, potassium trumps hypotension, and renin on the bottom of the pile. But if the renin is clearly high, we'll still act on that and increase their medication. So to summarize, the average person needs up to 50 to 500 micrograms of fludrocortisone daily. Younger people definitely need more. People who are doing a lot of exercise or athletes may often need these larger doses of fludrocortisone, 400 or 500 micrograms daily, to maintain their salt balance. Discuss salt cravings, including typical foods. Do consider giving salt tablets. So we quite often give sodium chloride tablets. It comes as slow sodium in the UK, 600 milligram tablets. So we give 4 or 5 of those. Often prior to exercise, people go to the gym and they sweat, and then they feel hypotensive and very weak after their grueling hour in the gym. So preempting that with salt tablets can be very helpful. Titrate, as I've mentioned. And the one last thing I'll say about this is, patients with primary adrenal insufficiency, they take their hydrocortisone every morning, and they know they've taken it. They feel better within half an hour, 45 minutes of taking the hydrocortisone. They can eat, their appetite comes back. But they miss their fludrocortisone out, and nothing happens. In fact, nothing happens for 2 or 3 days. So you need to explain to your patients what fludrocortisone does, because they'll regularly miss it out, and not appreciate that the reason they don't feel bad is because it has a long half-life and this effect on the salt supplies. So I guess I've done half an hour, and I'll stop now. But I'm very happy to take any questions from anyone, if that's okay, Amir.
Thank you very much. That was really interesting. So there's one question from Dr. Wren, Simon. Do you think there's a cause and effect question in the interpretation data? So those with poor quality of life get their dose increased, and therefore that is the reason for the poor quality of life?
Yes, exactly. It's reverse causation. You know, the people come to the clinic and people go, oh, we must do something about your poor quality of life or your tiredness. So they increase the dose of steroid, or they increase it to 3 doses a day. But the evidence that this is an effective strategy is absolutely lacking for when we look at these large studies. I'm not saying I don't do it, but it's not an evidence-based thing. And if patients are feeling perfectly happy on 2 doses a day, there's absolutely no reason to change that, because the evidence is that 3 doses is not superior to 2 doses by and large.
Thank you very much. I think in the interest of time, we'll move on. We've had to switch the order of the speakers, so Professor Meeran will go before Professor Arlt next. But Simon, thank you very much again for joining us.
Great, thank you very much, all. Can you hear me? Can I just check that it's all working? Yeah, and Amir's on mute, but I think he said yes. Okay. So look, I'm going to follow on from that. And I saw a question in the chat just now about how to assess people already on steroids. So I'll hopefully cover that too. I'm going to start really with a case. We're talking really about adrenal Cushing syndrome. Patients have got adrenal tumors that make cortisol, and what happens when you remove the tumor, and how to then deprescribe, if they're on them, steroids. So here's the case, right? There's a 28-year-old patient with adrenal Cushing. And essentially, in March 2021, this was about a year after lockdown, She had a baseline cortisol of over 500 and a suppressed ACTH. Okay, that would fit with adrenal Cushing's. And the other test she had done was a DEX suppression test. And as you can see here, she didn't suppress at all, 514. And they said 3 urine cortisols, and they're all very high. So this is not a subtle, this is an obviously very Cushing-like patient. And so we need to find the source. And clearly, if there's no ACTH, it's not pituitary and it's not ectopic, it must be an adrenal tumor. So here is a CT scan, and I'll just show you the spot here. So there's a liver at the front and a spleen at the back here. And I'll just scroll through it, and you can see this left-sided adrenal mass here. Okay, so that's a pretty reasonably sized 4 centimeter adrenal tumor that is the source of her cortisol. So the obvious thing to do is remove it. So there's a retroperitoneoscopic route that our surgeons use because the back is right there. So you don't need to mess with the bowels and the front, and you cure the patient. Such as a left retroperitoneoscopic adrenalectomy on the 10th of August 2021. We started the call of 550, and the next day it's a very low cortisol because that was the source, and so it's basically less than 50. And so now this was, I don't know if you remember, this was quite on and off lockdown we had that year. So she was sent home on prednisolone, which is what we use, and we'll say a bit more about that later. But she was sent home by the surgeons, and because they're so scarce and everyone's treating COVID, she was given a sort of random dose, 5 milligrams for 4 days, then 4 milligrams for 4 days, and then 3 milligrams from the 18th of August 2021. And then, because of all these lockdowns, she got lost to follow-up, okay? But she just stayed on her pred 3 milligrams daily for a whole year. And she said that she became unwell in December when we had another big bout of COVID. And she followed 6-day rules, and she doubled to 6 milligrams for 3 days, and then went back and was fine. So that seemed to be okay. And she also describes in March 2022, she was not seeing any doctors, right, for this whole year. She one morning forgot her steroids, her prednisolone, and she became unwell, and she started vomiting, and she thought, oh, maybe it's because I didn't have my prednisolone, and she went back on the 3 milligrams, and she said she was all right. This is with hindsight, okay? So she finally, 1 year later, got picked up by the system, and we saw her in clinic and did a Snackson test. Now, you heard Simon tell you about his tuberculous adrenal patient at a baseline cortisol of 298 and a peak of 319. So this patient had a baseline cortisol of 59 and a peak of 81, okay? So I'll just remind you, she's been on pred for a year, and she's had her adrenal Cushing's cured. And her baseline ACTH was 78. I think Simon's patient had one of over 1,000, but that's quite a reasonable ACTH. So there's the Snackson test on the left-hand top, just to remind you. And my options, I'm not going to need to vote because I haven't set it up, but I was asking people this question: would you switch her to hydrocortisone because she's going to fail? You want to cut the dose a bit? Do you want to leave her on 3 forever, or maybe she's a bit more? And I asked several people what they thought, and this is how they voted. So a majority said, look, let's switch to hydrocortisone because she'll be on that forever, 10-5-5, which is one of the options that that Simon mentioned was a possibility. I see someone put B. Okay, you're voting in the chat. We could do that, but I'm not going to do it because we don't have time. Okay, and then because people know that I like prednisolone, quite a few people chose to give her 3, and some say she needs a bit more. Okay, and I did another vote with a different group of doctors, and this was a spread. Okay, similar, but staying on 3 was very popular. Now, bear this in mind, right? She has had an adrenalectomy, and she has a normal pituitary gland, and she has a normal right adrenal gland that must have been suppressed for years before she was seen, okay, for years. And now she's on pred, which will persistently suppress her. So the issue really is that even an adequate replacement will prevent recovery, because if you give her enough steroid, whatever you give her, prednisolone, hydrocortisone, why will the axis recover? This is simple endocrinology. If you give someone a steroid, you will suppress the axis. And just to drive this point home, okay, there's my adrenal tumor making lots of cortisol. The pituitary gland will see that very high cortisol, and the corticotropes will be suppressed, and there'll be no ACTH for some years. And as a consequence of that, the other adrenal is atrophic. Okay, you then one day suddenly remove the adrenal cortisol source. The patient's cortisol falls to less than 50. You therefore start the patient on exogenous steroids. Some would give 10-5-5, some would give PRED3. In fact, according to Simon's data, we're clearly giving too much. And if you do that, if you give too much, then you will persistently suppress the patient's axis. And it's very difficult to not give too much because this patient is used to a very high cortisol. And so when you run them at a normal level, they have, as I'll explain in a minute, a withdrawal syndrome they don't like. Okay, but whatever you do, if you give too much steroid, you will cause this to not recover. Okay, so you need to keep on minimizing the dose because you want the axis to recover. Okay, because that's what you want. You don't want to be on steroids forever. We used to think it was all right. Because she's 28 years old. I don't want to be on steroids forever. And if you do cut the dose, there will be recovery of the ACTH axis. As you saw in this patient, it's 78, but the adrenal gland is still suppressed. It needs another year of ACTH stimulation, adrenocorticotropic, trophic meaning it will tropism, growth. And if you do give it underrun for long enough, you will get some recovery. And as that recovery occurs, you will start to see some cortisol. And we're pretty confident once it makes 200, you can get them off the PRED. So that's what we need to do. But which comes first? Because if you don't cut the PRED, you're not going to have any ACTH. So this is a real problem. We, as you know, use a lot of prednisolone now and been trying to work out what the right dose is for replacement purposes. And a couple of years ago, we looked at what we call lots of day curves to see how we metabolize prednisolone. And it looks like much lower doses than we've used historically are what we need to use. So, for example, if you plot this curve, and I've got now, that paper has got data on about 100 patients who are on basically between 2 and 4 milligrams of prednisolone once a day. So this yellow patient had 2 milligrams at 7 a.m. and is perfectly well with this sort of levels. But other patients are on 4 milligrams and have a much more rapid metabolism. So there is a difference in metabolism similar to hydrocortisone, but hydrocortisone is difficult because it's got such a short half-life that you get peaks and troughs all over the place. You can't see this quite so easily. So let's get back to this patient. Right, she's had adrenal out, and we're now in August 22, and I'm starting to do some tests on her. And this is when we were thinking prednisolone might be something to use. Is 3 excessive? So I did day curve on her, and at the end of it, 8 hours, her level was 17. Now, this is our therapeutic range. So I'll just go back to many of these curves we've done. And we find that patients that are at 8-hour levels of between 50 and 25 are well. Okay. And therefore, if you give them 3 milligrams, you're not going to have any recovery because the patients don't need it because 3 milligrams is a full replacement. So it wasn't excessive, but it is going to suppress. So we could say stay on 3 forever and goodbye. But a better thing to do would be, let's try and underrun the patient so that we can get a bit more ACTH, okay? Okay, because you can see the vote to cut was not very popular. Now, if you cut someone from 3 to 2, that is a 50% reduction in steroids suddenly. And patients don't like that. They have a steroid withdrawal syndrome. And I learned this from the vasculitis forum, having met lots of patients on big doses of steroids, and they all said, it's very hard to go from 3 to 2 because you really feel achy and unwell and you basically just stay on 3. But this is a protocol that we've been using for a while. And the way it works is if you give someone 2 milligrams before they really feel too achy, they go back onto 3. So this week 0 here, I'm on 3 milligrams every day. And then on Thursday, I have a milligram short. And before I notice, I'm back on 3. But the following week, I do it for 2 days, on Tuesday and Friday. And the following week, Tuesday, Thursday. And I slowly reduce it. And with 7 weeks, I cut by 1 milligram. And that avoids this syndrome of tiredness and achiness and steroid withdrawal. Okay, so that's basically how I think, and we've got more and more data on this, okay? And so basically by October, a couple of months later, you can see on 2 milligrams, it's better. Her baseline is the same. It's still quite high. But the baseline cortisol, still not as good as Simon's Addison's patient, but it's better. So there's clear recovery of the right adrenal now. 125, 137, 135. Oh, that way. And notice there's no increment. So this adrenal, this right, is maxed out by this ACTH, okay? And therefore the cortisol is going to be fixed and high. It's not, there's no circadian rhythm yet, okay? There's a high ACTH, and the recovering adrenal can't go beyond 137, okay? And it starts off at 125. So essentially, trying to reduce it slowly will slowly get things back. We're not right. This is not sufficient. She's on 2 milligrams plus a bit of endogenous adrenal function. Okay? And so cutoffs are not helpful because this is a fail, right? And if you look at this, most doctors would say, right, you need steroids forever. But that's clearly wrong. But in Simon's patient, it's clearly right. And the cutoff is 300. So 135, my basic message is we should not be using cutoffs. We use a clinical examination and history from the patient, because I'm going to give this patient off steroids, I hope, one day. If you give prednisolone once daily, you get a curve a bit like this. This is one that is a real curve into a patient, a very rapid peak and then a slow breakdown. And it's got a longer half-life than hydrocortisone because of this double bond here. Double bond is the only difference between prednisolone and hydrocortisone. And that basically changes its binding, and it changes its affinity, and it changes its half-life. So it lasts long enough to be, I think, perfect for once daily administration. And the problem with hydrocortisone, due to these little blips here, is that these peaks are unhelpful. So I thought, right, let's do another day curve, because I was a bit of research, to see what happens to your pred level. And clearly she's now underrunning it. Yeah, she was 17, now it's 10. So now on 2, she's on not enough pred to be replete, but she's obviously making about 100 nanomoles of her own. So we're going to make it, okay? And we're going to keep cutting, okay? And so I went down from 3 to 2 and then to 1. And on December the 2nd, she had a much higher CTH, with the pituitary becoming more and more exuberant as the corticosteroids recover. And the adrenal gland is slowly recovering too. And you can see I did a slightly prolonged synapsin test. 187 is the baseline. This is a fail. Not enough, okay? And it's not even going up much because, again, this adrenal is maxed out by this ACTH. So we've got a bit of a way to go, right? And so I did it. We said, right, we're going to underrun you. I warned her, you're going to feel a bit achy. But if we don't do this, you're going to be on steroids forever, which is not good for you in the long run. And same protocol, 2 to 1, 1 to 0. And when she got down to about here, I thought, shall we email the patient? And I said, Happy New Year. This was in 2023. I was saying, you're in week 18, so you're going to be 1 milligram. How are you? And she goes, I'm fine. I don't want any more testing. I'm feeling good. I'm feeling better on 1 than 2. Now, why is that? She's better, not because it's 1 and 2, it's because now she's obviously getting a circadian rhythm. I didn't think I could drag her back to hospital to prove it. But the reason that she's feeling better is not because 1 is better than 2, it's because she's making more of her own cortisol, which has got a circadian rhythm. And you can see her bone density obviously improves fantastically because she's now not got Cushing's, and I've not left her on steroids. So my first learning point really is we really have got to get people off steroids, okay? How long do I omit pred before measuring the morning cortisol? 1 day. In other words, I don't miss out at all. I just say to the patient, okay, we're going to do a cortisol on Wednesday morning. So have your normal prednisolone every day, but on Wednesday morning, just don't take it. Come to hospital, have a 9 a.m. or 8 a.m. cortisol, and then after that, take the pred straight away. So it doesn't change anything, but obviously in the morning, you saw the day curves. Okay, by the evening, it's all gone. So it's completely not in your circulation. And if you're measuring cortisol the next morning, you're measuring the patient's own function. So we need to try really hard, okay? And reduction in steroids causes this steroid withdrawal syndrome that patients really don't like. And the normal rhythm, we don't understand really. And I'm going to ask a question, which is, does it matter? Okay, some people say, look, it's really hard to keep you off steroids. Let's just leave them on it, okay? And the issue really is, if you're used to a high cortisol, it's really worth the deliberate underrunning to make people have the aches and pains in order to become independent. And here's a question the patient asked me: is it harmful to stay on lifetime replacement? Surely it's just a normal replacement. See, the problem is that if you're on replacement, you're stuck on it. And if you suddenly run out of steroid, you're in trouble because you have a crisis potentially. So it's really important to keep it off it, okay? And go through the aches and pains for a year or however long it takes. And this is a nice paper that describes a few other papers really, but there's a nice summary of the withdrawal syndrome following Cushing syndrome. And it applies to people who take high-dose prednisolone for all the conditions that we have, okay, acute asthma and more commonly the rheumatological problems. And they describe the difficulty we have with Cushing syndrome, still withdrawal syndrome, and insufficiency, all having quite a bit of different vague symptoms, as Simon described. They're vague: anorexia, can't eat, feel a bit naff. I don't know if it's adrenal crisis, if they're just withdrawing a bit, or actually if they're perfectly fine. Okay, it's very, very difficult. So we've really got to push and help people and explain to them it's really in your interest to follow a protocol like this and come off your steroids altogether. Now, I'll just tell you a bad story because this is the true thing, okay? Because I didn't used to do this, and I think most doctors in the past used to say, oh, it's okay. So here's a patient exactly the same, right? But 10 years earlier. So this is one of my patients, and I've mismanaged her, and I'm ashamed of it, but I must share this because I think we've taught people to do this and wrongly, we must unteach this. So this patient had a left adrenalectomy in March 2013 when she was 60 years old. And we sent her home in those days with hydrocortisone 10 plus 5 plus 5. And we did an SST near the end of the year. She had a low ACTH and she failed, right? Less than 20, 67, 86. And in those days, we used to do long synaptin tests, okay? And they're no better than short. There's no point doing them. But the definition of a pass for a normal person was a 24-hour sample had to be more than 900, okay? So in November 2014, this is a year and a half after her adrenalectomy, her cortisol on long synaptin were 112, 161, 190. So that would be a short synaptin test, okay, up to 190 of fail. And then it went 228, 268, and the next morning 653. So there clearly is some recovery potential. But by definition, that is a fail because it's not 900. And of course, it's not a pass because we know, compared to normal people, she's got a suppressed adrenal. So that's the peak long synaptin. Okay. So wrongly, I thought, okay, you clearly need to stay on the steroids. But I tried one more time in 2015, did another long synaptin test, and it was worse. Okay, so here you are. This is what happens if you leave on steroids. That's called adrenal suppression. I don't know why I'm teaching myself how simple technology works, but it's a fact. If you take hydrocortisone, you will suppress the axis. So then in 2016, we stopped doing long synaptins, and there's a short synaptin, 50, 172, 80. And she said, I'm absolutely exhausted. I feel so tired when I miss out my hydrocortisone. So we thought, shall I give her a bit more? Still the same dose, or reduce it? Despite the exhaustion. She's like, I can't not take this, doctor, okay? And I put that to vote. And because I told everyone I don't want to withdraw it, everyone voted correctly to reduce the dose. But this is now in 2024, I wrote after this talk, right? And we know why, because people die of too much steroids. There's increased mortality linked to insufficiency due to steroid exposure excessively. So this is in thousands of papers, including some of ours, okay? Anyway, go back in time to 10 years, even hindsight. She said, I can't cut the dose, doctor. 10.55, it's a normal replacement dose. And I thought, yes, normal replacement dose. She's unkeen to the dose, so we said, just stay on that. It's harmless. And she's exhausted all the time. When she misses a dose, she feels tired. She does a bit more sometimes. Sick day also gets a bit more. But if I ever do some action test, I know she's going to fail. So I thought, look, let's not bother. You'll be fine. We'll leave you on 10.55 for several years. She's getting older. She's now 69 in May 2022. She came into casualty with dehydration, nausea, vomiting, maybe a crisis, but she couldn't keep down the hydrocortisone. So it was a crisis, really. And remember, she's been on this now for 9 years. And she had adrenal Cushing before then, so she's got a properly suppressed axis. So we gave an IV hydrocortisone, and she recovered. So what happens next? Do we send her home? She's a bit older. She's a bit more frail. It took a little while to sort things out. And so she stayed in hospital for a couple of days. And in June 2022, she fell on my ward and fractured the femur on the ward. So we got all three involved. They did a magic job, stuck a nail in, did really well, but she got all the complications of an old person on steroids. Well, there's a fracture, so that's the first thing. She had a PE. She got pneumonia due to the anesthetic and the lack of inspiration. And then unluckily, because COVID is everywhere, she got COVID pneumonitis. And then she died. I think that the cause of death should have included the fact that I put her on hydrocortisone at the start, because she should now have been off it like my other patient. Okay, but nobody said that. They went, "Oh well, she's an old lady, you know." But I feel bad about this, and I think we should work better. And I've changed my practice now. I'm going to work very hard to keep people off steroids because, as it says in all the papers, there's an increased mortality linked to insufficiency due to steroid exposure being excessive. So I thought, right, there's a good message. I got this last year, right? This is in the Adrenal ADSHG magazine, right? This is basically the Addison's disease self-help group, okay? And they are basically very nice story. Nice old lady here, 80 years old, Ingrid, with her horse, and she's holding here a hydrocortisone emergency pack, okay? Me, Ingrid, go to the gym. And look at the story. I'll be 80 in May. In 2013, I was diagnosed with Cushing's syndrome, which is caused by a tumor of the adrenal gland, just like my patient. That year, I had an operation to remove one of my adrenal glands, and I now have Addison's disease. No, she doesn't. She has a suppressed adrenal. What do I do with this? I mean, this is everywhere. She's 80 years old, okay, and she's on hydrocortisone. She's going to ride a horse and have a fracture. Okay, this is the worry. I'm not going to interfere with this, but this is the problem, right? Everybody has the wrong message. They think if you've had Cushing's and take the adrenal out, you've now got Addison. She has one adrenal that could be woken up with a bit of work. So we have a problem, okay? We're not really training people correctly. There are many patients in the country who could come off steroids, and they've been told they should never do this, okay? And we're all scared of crisis, makes it really hard. And also, when they do cut the steroids, like we tell them, they feel achy and steroid withdrawal syndrome. So they say, "I'm having a crisis. I want to go back on my steroids." So that's the problem. It's a long way to go. Replacing steroids will suppress endogenous production, and we need to practice our deprescribing better. Because if any of you take hydrocortisone for 6 weeks, I just saw something in the chat there about something hydrocortisone. If you guys take 6 weeks of 20 and 10, you're going to fail a synaptic test. Okay, that is the main problem. Let me get to the chat. So the other important message is if you have someone who's on prednisolone and you want to wean them off it, stay on pred, okay? It's easier to wean pred than hydrocortisone because you've got to wean 3 separate doses. And of course, it looks now from some of the data we're getting, the late dose, the last dose you have, is particularly suppressive. So I'm going to stop at this point because I think I need to answer some questions and give time for Wiebke. But after adrenalectomy for adrenal Cushing's, patients do need steroid support. They can't not have any. But we've got to work very hard to get people off steroids if possible. Okay, and I think that's my last slide. Yes, thank you all. Are there any questions? I think there is one. Our standard protocol in post-procedure surgery is to give hydrocortisone 20 plus 10 for 4 to 6 weeks before a dynamic test as HP axis. Yeah, this applies to patients with no pre-existing secondary adrenal insufficiency. We're guilty of that too. So it's a good question. I think we're all giving everybody too much steroids. I think the message that taking steroids occasionally is harmless is not correct. And I think 6 weeks of 20 and 10 is going to increase the chance that your assessment some weeks later will fail. And we are using less and less, but it's hard work, okay? The work is convincing doctors to not be scared of adrenal crises. Of course, it's not good to have a crisis, but it's even worse to just dump people on hydrocortisone or prednisolone and forget about it. So I think you are, and I think we are too. I mean, we are now sending people home on 3 of pred. I used to have it 4, but even 4 is too much. So we start on 4 because they all get achy, depending on what the previous cortisol is. If the post-op cortisol is high enough, they don't go on pred at all. They go on nothing. So most patients go home on no steroid at all. If the cortisol is more than about 350, the number I made up. But if it's lower, everyone's a bit nervous and they will start steroids and they go home on 3 or 4 of pred. I'm trying to make it 3. And then we do an assessment like you after 4 or 6 weeks. There's a question there. Is it preferable to switch This is my bias. The evidence I have is that we don't use hydrocodone at all now at Charing Cross. All patients on replacement who start on steroids postoperatively go either on nothing or on prednisolone 3. We don't use hydrocortisone except by injection. So if you need injections, then of course there's only hydrocortisone. But any oral replacement is almost always prednisolone, unless from another center that's already on hydrocortisone. Now I'll leave them on it. But the evidence we're gathering makes me think that prednisolone is better, less suppressive, and present less side effects. And Pratik was asking, what are the ways to deal with? Yeah, so there were normal SST, and you just got to do it slowly. And it's lots of talking, therapy, because patients are aching for lots of other reasons. Okay, and so anybody who takes steroids, and there has been a study where you take healthy volunteers and put them on equivalent 10 of prednisolone for 10 weeks. That's quite a lot. And then reduce it to 9. And the aches and pain, and this is a nicely randomized blind trial, and they get lots of aches and pains as they go from 10 to 9. So it's hard work. And the answer is you need to support them and talk and tell them that they will succeed. Show them their SSTs are pass. Explain they will have aches and pains, but if they stay on steroids, they will come to harm like my other patient did. Thanks. I'm going to hand over to Amir. I'll stop sharing, actually.
Thank you very much indeed.
So absolutely delighted to be here again and to talk about diagnosis and management of adrenocortical carcinoma, which in the first part also includes talking about adrenal tumors in general, or in particular, the incidentally discovered tumors, so-called adrenal incidentalomas. So as you may know, adrenal tumors are like an iceberg problem. We currently pick not so many up of them, but we know from large data that 1 in 20 cross-sectional imaging scans actually detect an adrenal mass. And from autopsy studies, we know also that about 5% of people have a nodule in their adrenal. But obviously, most of those are relatively small. And I show you here a nice slide from a paper that Irina Bankos from the Mayo Clinic led on, and that really nicely illustrates that the majority of the tumors that are overall picked up are due to the discovery of adrenal incidentalomas. Yeah, you can see over the period from 1995 to 2025 to 2020, there were similar numbers of people picked up at cancer imaging or presenting with hormone excess, but the incidentally discovered tumors are actually driving the increasing number of adrenal tumors. So like it's estimated, as I said, 1.4 to 10% of adults have this, 5% in autopsy studies, and imaging studies show us 1 in 20 scans is actually having an adrenal nodule. Yeah, and this is primarily linked, according to several studies, and due to the incidental discovery of the increase of small tumors and in patients who are older than 40 years. It is important to know that patients who are younger than 40 years who present with an adrenal tumor, we should have immediately our red exclamation mark hat on, because this is something that could be worrisome and has a much higher likelihood of being worrisome than in a very old patient. So I would recommend all of you to look at the guidelines for adrenal incidentaloma that were run jointly by the European Society of Endocrinology, the European Network for the Study of Adrenal Tumors, and SAT, and the Endocrine Society USA was a co-sponsor. And the most recent guidelines came out in 2023. And this is an excellent document, and I can only recommend to you to read it. It is open access in the European Journal of Endocrinology, so you can freely read it even if you're not a member of the European Society of Endocrinology. So when you have an adrenal tumor or an adrenal incidentaloma, an incidentally found adrenal tumor, you have 2 important questions. Firstly, is there hormone excess derived from the adrenal? And secondly, is there evidence of malignancy? And obviously for the patients, this is the most important question. If you tell a patient they have a tumor, they will say, do I have cancer? But obviously cancer is rare, yeah, in the patients that come to diagnostic, and these are only the patients usually with larger tumors, about 5%, 1 in 20 again, have adrenal cancer in large series from specialist centers. So what do we do in general in adrenal tumors? And obviously you heard already about primary aldosteronism and Cushing's. We need to exclude primary aldosteronism. We need to exclude Cushing's. Adrenal androgen excess, the increase in DHEAS or androstenedione or the precursor steroid 17-hydroxyprogesterone, in particular in tumors that are large, can be a hint towards a high potential of malignancy of being an adrenocortical carcinoma. Adrenal androgens are only in exceptional cases is the excess of adrenal androgens observed in benign tumors. This is usually a worrisome sign. And obviously, in principle, we don't talk about this in the session today, that we need to exclude pheochromocytoma with plasma metanephrines or urinary metanephrines. So a couple of slides on mild autonomous cortisol secretion, MAX. This is also all described in detail in the EGE guidelines. And MAX is defined as somebody who failed the overnight dexamethasone suppression test. So the 1 milligram dexamethasone at 11 p.m. and then bloods for cortisol 8 to 9 a.m. the next morning. But has no overt features suggestive of Cushing syndrome. Yeah, and obviously this is not a black and white diagnosis, but it's a spectrum. Yeah, the cutoff is at 50 nanomoles, or if you are operating micrograms per deciliter, 1.8 micrograms per deciliter after overnight suppression. And most patients are in this area, but older patients, more obese patients may be slightly higher. And but there is then a cutoff where we say this should be considered mild autonomous cortisol secretion. Yeah, but we need to work not so much with the cutoff, but with the interpretation of the results as a continuum. Okay, so and what is important is MAX is the most common abnormality that is found hormonally in adrenocortical tumors. Like 30 to 50% of the patients in large cohorts have evidence of MAX. And what has been shown in a number of papers from large cohorts, that MAX is associated with an increased prevalence of cardiometabolic disease like type 2 diabetes and hypertension. And importantly, 70% of patients with MAX are women, mostly are of postmenopausal age. And it has been also shown in a large study of the European Network for the Study of Adrenal Tumors that came out 2 years ago, that the women that women are actually the ones, in particular women that are younger than 65 years, who have the highest increase in mortality in association to having been diagnosed with MAX. Yeah, so the green line here is autonomous MAX, mild autonomous cortisol secretion. You see a significant acceleration of mortality in this group. Obviously, we have to be careful that this is a retrospective analysis, yeah, but this is a strong indicator that we should be aware of this. Okay, so then the second important question, obviously, and the main thrust of the talk is malignancy. Yeah, that is what our patients are worrying about. Do I have cancer? And so basically, the adrenocortical carcinoma guidelines have also been published in 2008, in 2018 in the European Journal of Endocrinology. And there is a guideline from 2020 in the from the European Society of Medical Oncology and the European Network for the Care for Adults with Rare Solid Tumors, Rare Solid Cancers. And but as you can see with the author names, relatively similar people are involved in this. Yeah, so this is a slight update in a way of the European Society guideline, which will undergo an update soon. But again, I can really recommend you this document. Okay, the important thing is obviously that adrenocortical carcinoma is a highly malignant tumor that still has a poor prognosis. Yeah, it is rare. I told you, however, that it accounts for 1 in 20 of adrenal masses that undergo a diagnostic workup. And differentiating adrenocortical adenomas, the benign tumors, from ACC represents a continuous challenge. And imaging, and I will tell you, I will show you detailed data, provides high sensitivity. So it picks up tumors reliably, but they have poor specificity in deciding whether a tumor, an adrenal tumor, is benign or malignant. And as you may know, biopsy is, as a basic measure, not suitable because a pathologist cannot differentiate between a benign and a malignant adrenocortical tumor on the basis of a biopsy. Yeah, so they often struggle even if they have the whole specimen. A biopsy is only useful if I want to diagnose a tumor that is not of adrenocortical origin. So it is important to think that early surgery is the only option for effective cure of ACC. So that means we really need to accelerate the speed of accurate diagnosis. But on the other hand, we have shown in the UrinAct study that 38% of the patients that currently undergo adrenal tumor removal actually turn out to have a benign and non-functioning tumor that would not have required surgery. Yeah, so that means we also need to avoid unnecessary surgery. So I told you about the UrinAct study, and here all the people that have been involved in this all over Europe. And UrinAct collected more than 2,017 patients with newly diagnosed adrenal tumors that have been recruited over a period of 5 years. And 84% of those were actually incidentally discovered. So that is the largest prospective study ever in adrenal tumors. And this gives us a lot of useful information. So if we look at what is in the 84% of cases that are adrenal incidentaloma, what are the underlying diagnoses? Yeah, so these are 1,685 incidentalomas, and 90% of those are benign adrenocortical adenomas. Yeah, some have Cushing, some have primary aldosteronism, but this is a rare occurrence. Many have MAC, mild autonomous cortisol secretion, but the majority is non-functioning and benign. Then in the incidentaloma cohort, we had 3% adrenocortical carcinomas. And then if you recruit such large numbers of tumors, you find also non-adrenocortical tumors, which can be metastases of extra-adrenal primary cancers, and it can be obviously adrenal medullary tumors, pheochromocytomas, but also other benign masses like gangliocytomas or other malignant masses like sarcomas. Yeah, so this is important to have in mind, though this is quite rare. So this is the overall split that we observed in the overall cohort. Yeah, we achieved like 4.9% ACC in the large UrinAct cohort. So first you can do CT imaging or MRI imaging to determine the tumor size. And I show you here the comparators so that you have an idea how big is a 2 centimeter, 3 centimeter, 4 centimeter, 5 centimeter tumor. 5 centimeters is as big as a lime. Yeah. So like, and here then we have a peach. Yeah, we have a grapefruit is 10 centimeters. So these are large tumors in principle. And you see that the majority of ACCs are large, and only 2 patients were actually smaller than 5 centimeters. And you could say, hey, why? Then we can just take these. But the problem is that overall ACCs are rare. You see the y-axis here goes up to 15 only, while here are hundreds and hundreds of patients. So it is important to recognize that still many, many more benign adenomas, adrenocortical adenomas, will be larger than 4 centimeters. Then large ACCs will be detected. Therefore, size alone, yeah, the diameter of the tumor, does not perform sufficiently. And this is what you see here. The best cutoff is actually 4 centimeter. Yeah, it has a sensitivity of 98%. and a specificity of 80%. Yeah, so like 80% is obviously poor. Yeah, but if you go to 6 centimeters, then you miss a number of tumors, and you don't want to miss an ACC. Yeah, 80% specificity for tumor diameter. Then the next option we have is with unenhanced CT. So that means with a CT where we do not have given contrast agent, yeah, that we can measure the density of the tumor in Hounsfield units. Yeah, Jeff Hounsfield won the Nobel Prize for this discovery, so that you can measure the tissue density. Negative tissue density is usually equivalent to fat. Water has a Hounsfield unit of 0, and typically malignant tumors, but also many lipid-poor benign adenomas will have high Hounsfield units. Yeah, so lipid-rich, we typically find adenomas and myelolipomas that are also benign, but lipid-poor, we have adrenocortical carcinomas, metastases, pheochromocytomas that we would obviously also sensitively and specifically detect with plasma metanephrines. But as I said, hundreds and hundreds of lipid-poor adenoma have also an increased Hounsfield unit measurement, which again reduces the specificity. And these are the numbers from the Urine Act study. And that shows, if you take the old cutoff of less than 10 Hounsfield units indicating benign tumors, then actually 1/3 of the benign adenomas were suspected to be malignant. Yeah, and the study actually helped us to look at other cutoffs. Yeah, so, and you see the information here. And this actually showed that it is much better to use a Hounsfield unit cutoff of greater 20. This still gives you almost 100% sensitivity, but it gives you a much higher specificity. Again, it's not a great specificity, but 80% is miles ahead of 64% specificity. That means if you use 10 Hounsfield units, you will actually misdiagnose a lot of patients as false positives. So suspect them to be ACCs, though they aren't. And so raising the cutoff from 10 to 20 Hounsfield units in the Urine Act study meant that we decreased the false positives, patients that are wrongly suspected to have ACC, from 423 to 200 patients, and 99% of the ACC patients remain true positive. Another imaging approach is FDG PET, which is highly sensitive, but not very specific. Yeah, and it's much more specific than other measures. But and what is important, if the FDG PET is negative, if the tumor is not taking up FDG, fluorodeoxyglucose, this tumor obviously is an ACC that shines light because it is so metabolically active, it takes up a lot of fluorodeoxyglucose. But if the FDG PET is negative, then the adrenal tumor is very highly likely not an adrenocortical carcinoma. However, the problem we have is the FDG PET is positive. It may be cancer or not. And a recent study that is about to be published imminently, which was led by Steffi Hahner, has actually shown that FDG PET is good as throwing a dice if it's positive. The cancer may or may not be a cancer, the tumor. It's only 50% specificity. So we have introduced urine testing, and that's a test that hopefully soon will come to you. And so we measure with mass spectrometry the urine excretion. And obviously, as you know, there are lots of steroids in urine, the excretion of androgens and other sex steroids, the excretion of blood pressure steroids like the mineralocorticoids, and obviously cortisol and stress hormones, the stress or flight regulators are also excreted big time in the urine of adult patients. And we used this hypothesizing that a benign tumor would produce more end products of adrenal steroidogenesis, but an ACC, an adrenal cancer, would produce more precursor steroids that we do not routinely measure. And we did this in a proof of concept study, you know, like where we looked at the urines of patients with benign adrenocortical adenoma and malignant adrenocortical carcinoma, measured all their urines with mass spectrometry, and then basically did machine learning analysis. And this actually revealed a steroid fingerprint that did not only have 90% sensitivity, but 90% specificity, which is much higher than any imaging test. And this tumor detection method was then transferred to a high throughput platform by Eng Taylor in the lab, from low throughput GCMS to high throughput LCMS, and we trained a new algorithm for this. And this showed that LCMS is measuring very similar to GCMS on the left side. And then we applied this actually to machine learning algorithms, and that again showed that the high throughput method is similarly effective. And this high throughput method was then used and applied to all the 2017 urines from the Urine Act study. And the machine learning algorithm that we had trained was then able to determine if there was a low risk or high risk of the tumor being ACC. And here I show you the results, and it compared tumor diameter by CT to tumor density by CT to urine steroid metabolomics, the urine test. And you can see here in blue that the number of false positives is much higher with diameter, tumor diameter, or tumor density by CT. If you combine two of the tests, you can see that the urine test helps to shrink down the false positives by still maintaining very high true positives. And if you combine diameter with tumor density and the urine tests, you get actually the best performance. Yeah, so this is a new triple test. We published this in 2020, and we are now working hard. We just got our second grant from Innovate UK to introduce this test to clinical practice in the UK and also soon in Europe. So how should we handle an adrenal mass that we suspect of malignancy? What kind of tests should we do? So we have an unenhanced CT adrenals, and we measure the tumor diameter and the tumor density. So if the tumor is small, yeah, in any size with a Hounsfield unit of less than 10, and a tumor that is less than 40 millimeters and has a Hounsfield unit from 10 to 20, in the Urine Act study, actually no patient in this group, these were 1,100 patients, had an ACC. Yeah, so like no further imaging is required. If you're in the intermediate group, that means you have a larger tumor, greater 4 centimeters, and your Hounsfield unit is intermediate, 10 to 20. Or you have a small tumor, but your Hounsfield unit is higher than 20, then there is a very low risk, 0.7%, that you have ACC, and there are some other malignant tumors. So the recommended action is interval imaging after 6 to 12 months. However, if you have a large tumor, greater 4 centimeters, and a high density, then you have a high likelihood of ACC and also a high likelihood to have another malignant tumor. And for this group, we would recommend the urine test as soon as it is rolled out. If it's positive, patients go to surgery, accelerating their access to surgery. If it's negative, the patient gets an FDG PET-CT. If it's positive, the patient goes to surgery because we increase the pre-test likelihood. And if it's negative, the patient undergoes interval imaging. Good. And what do we do if we have operated on adrenocortical carcinoma, or if we want to operate on a patient who is suspected to have adrenocortical carcinoma? Yeah, so usually we do this via open adrenalectomy. But obviously, it's also possible to go via laparoscopic adrenalectomy, which is usually the gold standard for benign adrenal tumors. So in principle, this is what the guideline says. If you have hormone excess and you have the suspicion of an adrenal malignancy, then it depends on the size of your tumor and of if you have local invasion. Yeah, so like sort of if radiological suspicion of malignancy is there. And then we say, is there local invasion, yes or not? If there is local invasion, then you should always operate open, and it should be done by a surgeon who does at least 20 adrenalectomies per year. If there's no sign of invasion on the imaging and the tumor is less than 6 centimeters, then an experienced surgeon can do minimally invasive adrenalectomy. If the tumor is larger than 6 centimeters, then generally an open approach is recommended, but it can be individualized dependent on the individual patient and their requirements, and obviously also on the surgical experience and expertise present. So there's also a new score, the ESCRA score, that allows us to prognosticate how serious the diagnosis of ACC is. Do these patients have a high likelihood of recurrence, yes or no? And a key parameter is really the Ki-67 proliferation index. So this is super important. But we also know, obviously, it's important what is the NSAID stage of the tumor. What is the resection status? It has all the tumor come out. Is it an old or young patient? And are there any hormone excess symptoms? And this ESCRA score has been developed by Yassir Al-Hassan and Christina Ronke in collaboration with NSAID in the center in Birmingham. And it showed very convincingly that it performs better than the previously used NSAID stage or Ki-67 index alone. It is now a very valid prognostication tool. It has been also very validated now in 2 independent cohorts, so it can be considered a state of the art. You need to have access to a very experienced adrenal pathologist that is expert in the diagnosis of adrenocortical carcinoma. So you have adjuvant therapy options. You can give radiotherapy to the tumor bed. You can give cytotoxic chemotherapy like cisplatin-based short pulses, but the most common is mitotane. This is autopara DDD, a derivative of DDT, and is the only officially approved drug for ACC. Officially, it's used for advanced disease, but it's routinely used for adjuvant disease. For adjuvant treatment. It is important that you measure the serum concentrations, which is offered by the producer. And you should be aware that the patients often struggle to swallow these tablets because they are 1.3 centimeters in diameter. Often they have to be crushed and eaten in yogurt or something else that helps this to invade. And finally, an important study I want to end with is the Adjuvo study that was published in 2023, and we were also able to contribute to. This was the questions: do patients who have a Ki-67 proliferation index of less than 10%, do they really also need mitotane? It was very painful to do the study, which took a long time. But the results were convincing that it is not necessary strictly that patients with Ki-67 less than 10% really need to take mitotane. It's an individual case-by-case decision. So, and I end on this slide, which I'm grateful to Martin Fasnacht. He gave this to me as his favorite summary slide. And this is actually the decision: what do you do with a patient with localized ACC? Is it amenable to resection? Then do surgery as radical as you can. If the histology shows Ki-67 of less than 10%, then decide either for active surveillance or consider mitotane in discussion with the patients. If it's higher than 10%, go for adjuvant mitotane. And if it's a very high risk, and then you should, it's listed here, greater 30%, large venous tumor thrombosis stage 4 or 1 resection, then you should consider adding cisplatin. And obviously, if you have not a complete resection, then you can use mitotane and also consider radiotherapy of the tumor bed where the residual tumor is. So like, I'm not talking today about advanced therapy that's so specialized, but I hope I could give you a good overview of what to do with benign and malignant adrenal tumors. Many thanks.
That's the switch size cutoff for angiomyolipomas would you refer for adrenalectomy?
Okay, that's an important question. Yeah, like sort of the indication is that if adrenal myelolipomas are greater than 8 centimeter, they have a tendency to continue to grow. Yeah, so what we usually would say, it's indicated in patients who have a large adrenal myelolipoma to do imaging follow-up to see if they grow, because they can become really very large and can lead to compression symptoms. Yeah, but I would first establish through follow-up imaging whether they grow. Yeah, but you don't need to follow every little adrenal myelolipoma, but the cutoff for me for imaging follow-up is 8 centimeters.
Fantastic. Thank you ever so much. Really grateful for joining us, Professor Arlt. So the event is accredited by both Department of Health Abu Dhabi and the Royal College of Physicians. So you can scan the QR code that is being presented now, and please spell your name carefully because that's how it will appear on the certificate that you shall receive shortly. And for Department of Health Abu Dhabi licensed clinicians, please apply via TAM. The details are put in by Erin in the chat. Please remember, thyroid masterclass will take place on 21st of February. So if it's not in your diaries, please make a note of that, and we look forward to seeing you then. Thank you very much again for joining us.